Thank you for the opportunity to tell you about my research. I'm a clinician scientist, and that means I both see patients and I do research. In my research, I consider myself to be something of a science detective, performing experiments to obtain clues into the mysteries behind health and disease. The mystery that we're investigating is systemic autoimmune rheumatic diseases, or SARDs. These are conditions such as lupus that affect multiple tissues and in which the immune system attacks our body's own tissues instead of targeting infections. We don't really know what causes these conditions, and that's the mystery I'm trying to solve. Lupus affects 1 in 1,000 Canadians, including many young women. It can be a devastating disease, and it's complicated to treat because it varies in how it presents and how it changes over time. A number of patients have a relapsing and remitting course, in which they have prolonged periods of low or mild symptoms that are interrupted with periods of increasing symptoms called flares. A flare can be as simple as having a skin rash or joint pain, but it can also be very severe with inflammation of the heart, the kidneys, or the brain. We don't know how to predict if and when flares will occur, but if we could do this and intervene, we could prevent much of the heartache associated with this condition. So imagine I'm in my clinic, and before me, I have 3 patients. All of them are 25-year-old women with a positive ANA or anti-nuclear antibody test. This is the gold standard test we use to make the diagnosis of these conditions. Patient number 1 has no symptoms. This is uncommon because 25% of women actually have a positive ANA test, and the vast majority of them will be completely healthy and never develop disease. Unfortunately, there's a small subset of these patients which will be asymptomatic patients in the early phase of lupus. With this patient, I would like to be able to predict who is going to go on to develop disease, and I would like to be able to intervene and prevent it. Patient number 2 has early onset lupus. This is manifested by a skin rash and joint pain. With her, I would like to know how severe is her disease going to become, and how likely is she to re-flare in the next year. Patient number 3 has serious disease. She's admitted to hospital with kidney inflammation. We initiate treatment, but she fails to respond and develops impaired kidney function. In her case, we would have liked to be able to predict how severe her disease is and whether she'll respond to therapy at the time of her flare. In my lab, we do in-depth analysis of the immune system and immune cells, as well as the proteins they produce. And this has led us to appreciate that a set of molecules called interferons play a very important role in the immune disruption that occurs in these conditions. So going back to the clinic, how has this impacted patient care? Well, for people like patient 1, we've shown that in asymptomatic ANA positive women, a certain percentage of them have high levels of interferon, and those with the highest levels are at increased risk of progressing to disease over the next few years. And we've begun to obtain some very interesting insights into the immune mechanisms that lead to this transition. For patients like patient 2, we were the first people to show that high levels of interferon are associated with more severe disease. And we've also shown that one of the mechanisms by which this occurs is that interferon acts to promote the development of the immune cells that produce the tissue-damaging antibodies, and that the failure to normalize these immune cells with treatment results in recurrent flares. And finally, for patients like patient 3 with severe disease, we have begun to identify the immune profile that's associated with poor responses to treatment. What I find so rewarding about doing research is we get to solve, or try to solve, really important puzzles every day. As science becomes more complex, it becomes increasingly more collaborative, and together we have made some very important advancements. The pieces of the puzzle are coming together, and it's only a matter of time till this leads to early, more personalized therapy and better outcomes for our patients. Thank you.
Don't go anywhere yet. So Joan, I was interested that you said 1 in 1,000 Canadians is affected by lupus, right? And that many of these are young women. So why young women, and how would that play a role in your research?
So the ratio of women to men with lupus is 10-1. And this is because women have 2 X chromosomes, and that many immune genes are on the X chromosome, and we tend to have a higher response than men to various immune challenges. And also, sex hormones play a very important role in the immune system, and estrogens lead to enhanced responses. Both of these things cause women to make higher levels of autoantibodies and to develop lupus. And how does this impact our research? Well, we have to study both men and women, but we have to be sure that when we compare a healthy person with someone who has lupus, that they are matched for sex, or we might be identifying sex-related differences rather than disease-related differences.
Oh, wow. Okay, fascinating. Thank you so much. That's Joan Wither.